Hi everyone. Today we'll be discussing December 2021 paper 1 DNB questions. I have completed first question. Now going to the second question. That is enumerate various midline neck masses in pediatric. We have midline neck masses pediatric patient. For this they have given 2 marks and then discuss the embryological development, clinical presentation, imaging features of thyroglossal duct cyst. So we have 4 questions in this second question. That is for embryology, they have given 2 points, and for clinical presentation 2 marks, and for imaging features 4 marks. Total are 10 marks. So the first we have to know what are the neck masses in pediatric patients. Neck masses in pediatric patient. Before going to that, we'll be discussing something about this. First, ultrasound. Any patient comes with a swelling in the neck, choice is ultrasound. It is the imaging method of choice. Then MRI. MRI is useful for large lesions to determine whether the lesion infiltrates into the deeper spaces, to know if the lesion is going into the deeper spaces. Then CT. Why we do CT? CT in a neck mass, like especially if they are acutely ill with infections, to assess whether the abscess is present. Okay. Then going into what are the neck masses, pediatric neck masses in pediatric patients. For this they gave 2 marks. Then I'll be telling even solid masses, and first we'll go into cystic masses. Cystic masses, we have midline. This is only in the pediatric patients. Cystic, we have midline masses and lateral masses. In midline we have ranula. This is ranula. We have thyroglossal cyst and dermoid cyst. Only 3, just remember, 3 midline cystic masses in pediatric patients are dermoid cyst, we have thyroglossal cyst and ranula. Remember, ranula, it occurs in the upper aspect of the neck. Thyroglossal cyst, I'll be discussing about it, and dermoid cyst mostly in the lower part of the 3 midline neck masses. Coming to lateral masses, lateral neck masses in pediatric patients are branchial cyst. We have a branchial cyst, we have lymphangioma and vascular malformation. Here also 3 branchial cyst, we have lymphangioma and vascular malformation. So here we have mandible, head bone, laryngeal cartilages with the thyroid cartilage with thyroid gland, and down we'll have trachea, sternocleidomastoid muscles and carotid vessels. So midline neck masses, ranula, thyroglossal cyst, dermoid cyst. Lateral masses, branchial cyst, lymphangioma. Other we have fibromatosis coli. It's very easy. Coming to solid masses. In solid masses we have lymph nodes other than lymph nodes. So in lymph nodes we have reactive nodes. It can be due to reactive nodes or lymphadenitis or lymphoma. 3 lymph nodes, lymphoma, lymphadenitis, reactive nodes. Then solid other than lymph nodes we have, it can be due to thyroid lesion, fibromatosis coli, pilomatrixoma, ectopic thymus, rarely teratoma, rhabdomyosarcoma, neurofibroma, neuroblastoma. These are other solid lesions within the neck. So our question is midline neck masses. We have midline neck masses in the pediatric patients. So midline neck masses, pediatric patients, midline. So 3, ranula, thyroglossal cyst and dermoid cyst. So you have got 2 points. Then coming to embryology, clinical presentation and imaging features of thyroglossal duct cyst. Discussing about the embryology. This is the tongue, this is the base of the tongue, head bone, thyroid cartilage and thyroid gland. We have trachea. This is the foramen cecum. This is the foramen cecum. These are all the situations where the potential locations of thyroglossal duct cyst and ectopic thyroid tissue. If this part is not gone, we can find thyroglossal duct cyst or ectopic thyroid tissue at the base of the tongue, suprahead location, at the level of the head, infrahead location. In any of these locations, we can find the thyroglossal duct cyst. Coming to embryology. So coming to embryology. So what happens? This is the first and this is the second pharyngeal pouches. Normally the thyroid originates between the first and second pharyngeal pouches near the base of the tongue. What happens in the third week of gestation, around day 20 to 24, the endodermal, this is the primitive pharynx, the endodermal cells of the primitive pharynx, they proliferate and create a thyroid diverticulum. They proliferate and create a thyroid diverticulum. So then what happens, beginning in the 5th week of gestation, foramen cecum from here, the thyroid, what happens beginning in the 5th week of gestation, the thyroid diverticulum, it migrates caudally along the midline, crossing anteriorly to the hair bone and laryngeal cartilages. So during migration, the thyroid remains attached to the tongue via thyroglossal duct. This is the thyroglossal duct. So in the early descent, the thyroid, normally this thyroid will be hollow organ. So while descending, it solidifies and forming the follicular elements. Then division of the thyroid into right and left lobes occurs in the 5th week of gestation. What happens during this, by the 7th week of gestation, the thyroid has reached the final destination in the neck. Normally the thyroglossal duct, this thyroid is attached to the foramen cecum by thyroglossal duct. Normally by the 7th week of gestation, the thyroid has reached the final destination of the neck. Normally the thyroglossal duct degenerates by the 10th week of gestation with only the foramen cecum to indicate the formal existence. So this everything, the thyroglossal duct, it will disappear. So by 10th week of gestation, it degenerates. So in some instances, incomplete obliteration of the duct can lead to thyroglossal duct cyst. It can also lead to lingual thyroid or pyramidal lobe. So this is about the embryology. So here you can see the thyroid primordium. Here you can see the thyroid primordium, foramen cecum of the tongue, thyroglossal duct. It connects from the thyroid, developing thyroid to the foramen cecum. Here this is the site of, this is the foramen cecum, this is the thyroglossal duct. Here we get the future thyroid gland. Normally by 10th week, this thyroglossal duct, it degenerates. If it remains, it leads to thyroglossal duct cyst formation. So embryology is over. You got 2 points. Then coming to clinical presentation, there is a painless rounded midline anterior neck swelling. There will be anterior neck swelling. If there is no infection, there will be painless rounded. If infected, there will be a painful lump which is red and warm. Normally it moves with swallowing. Classically, it elevates on tongue protrusion, something related because it is a connection between the future thyroid and the foramen cecum, the duct will be present. So when you protrude the tongue, it also elevates. On swallowing, it moves. So these are the clinical presentation and you got 2 points. Failure of the normal developmental obliteration of the thyroglossal duct during development leads to thyroglossal duct cyst. Normally, foramen cecum anterior, in the midline it goes above the hair bone, anterior to the hair bone, anterior to the laryngeal cartilages. So thyroglossal duct cyst, if it doesn't get degenerated, so it can form anywhere. So most common location is infrahead. So most common location is infrahead. It can be suprahead or at the level of the hair bone. So these are midline cysts. Midline means within 2 cm of the midline. So inferior lesions tending to be off midline. If the cysts are inferiorly, they tend to be off midline. So coming to imaging, first is ultrasound. So normally on ultrasound, it appears as a planeless fluctuant cystic structures. They splay the strap muscles. Normally if you take the anatomy, if you take this section, we have vertebra, we have longus colli muscle, we have esophagus, we have a trachea. This is at the level of the thyroid. This is the thyroid gland, common carotid artery, internal jugular vein. Then we have sternocleidomastoid muscle and strap muscles. We have 3 strap muscles, that is sternohead, sternothyroid and homoeoid. These are the 3 strap muscles. So how it presents on ultrasound, it is a painless fluctuant cystic structure. These are midline structures. This is a midline structure. Here the cyst might be there. Some midline means off limit, within 2 cm of the midline can also it can be there, cyst. And they splay the strap muscle. These are strap muscles. They splay it with as the cyst there is posterior acoustic enhancement. So that painless fluctuant cystic structures which splay the strap muscle with posterior acoustic enhancement. So On ultrasound, there will be hypo or anechoic. The walls will be thin without internal vascularity. In some cases, the fluid contains debris, septa and internal echoes. This is due to proteinaceous material. Normally, there will be anechoic or hypoechoic with thin walls without internal vascularity. If the proteinaceous material is present, they may contain debris, septa or internal echoes. So how an infectious cyst look? Infectious cyst will be thickened or irregular walls with increased blood flow and surrounding inflammatory changes. Then soft tissue lesion associated with the cyst. If there is a soft tissue component within the cyst, it may be ectopic thyroid tissue within the cyst, rarely carcinoma. Carcinoma, which carcinoma? Papillary origin. So on ultrasound, what you have to see? Midline structure, anechoic, no thick walls, thin walls, without any vascularity, non-infected cyst. If there is any proteinaceous material, will have debris. Infected cyst, they'll have thick and irregular walls. One thing you have to find out, if there is any solid component within it, if there is any calcification within it, just to rule out if there is any carcinoma, we have to rule out. That's papillary carcinoma. The solid component can also be due to ectopic thyroid tissue, soft tissue component. Then coming to CT findings. On CT, how it appears? CT findings coming to thin wall, smooth, well-defined, homogeneously fluid density lesions with an anterior midline or paramedian location, like within 2 centimeters of the midline. So they are homogeneously fluid density lesions. They have slight capsular enhancement. The sternocleidomastoid muscle. So this is the sternocleidomastoid muscle, displaced posteriorly or posterolaterally. Normally, in some cases, the cysts get embedded in the infrahad strap muscles. These are the CT findings. Coming to MR findings. On T1, it is variable. For example, if there is uncomplicated and low protein content, there will be low signal within the T1, there is hypo intense. If there is previous hemorrhage or infection or high protein, that is due to previous complication, high signal. On T1 later, if there is high signal, it is due to hemorrhage or infection, previous hemorrhage or infection or high protein content. On T2, that is T1. On T2 is typically high signal intensity will present. Coming to contrast, normally there will be no enhancement in uncomplicated cysts and thin peripheral enhancement may be seen. Coming to complications, it may get infected, malignancy less than 1% of cases, papillary thyroid carcinoma most frequent, presence of calcification is suggestive of malignancy, intracystic soft tissue is will be present, it's very less specific. Thank you so much. Just like and subscribe my channel.